Alrighty. Hello, everyone. Welcome back to PS Platypus. Today, we're going to be taking a look at a gastrointestinal systems review. This slide set is going to be a bit more content heavy than our usual slide set because it contains both the questions themselves as well as the associated pathologies. So it'll be a bit more content heavy, but it'll be useful for your OSCEs and your examinations because for your OSCEs, you'll have to memorize the questions themselves. But then when it comes to your exams, you're going to have to know how to link some of those symptoms with an underlying disease process. So without further ado, let's get started. So as with any history, we're going to be looking at pain first of all, but in a GIT history, you're going to be focusing on abdominal pain. And as usual, you're going to be going through a WWQQAA bias. In particular, you want to focus on the where component of that because the location of the pain is very well linked to the underlying disease process. And you can have a look at the diagram on the bottom there, which shows some of those locations and affected structures. Now, you don't have to memorize that whole diagram there. It's quite big and complicated, but I've got some of the common conditions that you can keep in mind summarized on the table on the right. So the very first one you want to keep in mind is with appendicitis. You're going to be asked about that time and time again in exams, in OSCEs. Typically, the way it presents is initially it's epigastric or periumbilical pain, so around your belly button. And then it starts to migrate to your right lower quadrant as time goes on. And the next pathology we have up is GORD or gastroesophageal reflux disease, or commonly called heartburn. That's where you have a bit of acid reflux in your esophagus, and you generally feel the pain in your throat region or even just in your central chest retrosternal area region. And you'll often hear that pain is improved after vomiting. It might have something to do with the fact that vomiting sort of empties a bit of your stomach of the acid and the esophagus as well. And then the next up, you also have peptic ulcer disease, which typically presents with an epigastrial pain, which can move to the back. What you'll find is with this one, it's worse or better after meals, depending on where the location of the ulcer is. And again, you're going to be covering exactly why it's worse with gastric ulcers after meals, but better with duodenal ulcers after meals in the corresponding lecture. We won't go over it too much today, but probably another important one to keep in mind for peptic ulcer disease is that it's associated with NSAID use. The idea being that NSAIDs reduce they inhibit the production of prostaglandins, which usually have a protective effect on the gastric mucosa. And so because of that, you're going to have these ulcers forming in the mucosa. Another important to keep in mind is that it's relieved with antacids and again with vomiting because you're removing the acid that's aggravating the ulcers. You also have bowel obstructions. Now, bowel obstructions, simply enough, they're relieved by defecation because you're removing the obstruction itself. They're colicky because colicky pain, again, is pain that comes and goes, often referred to as sort of spasmy pain or pain that comes in waves. And the reason you can get colicky pain is because you have some sort of tube in your body that's being obstructed. And the most common tubes that are affected usually are the bowels and the ureters because they undergo some sort of peristaltic action. And so when there's an obstruction and they're trying to undergo peristalsis, they get that wave-like pain or spasmy pain. You also have peritonitis, which is inflammation and irritation of the peritoneum. And that's something which is often resolved when the patient tries to be as still as they can, because that way they're avoiding any of your internal abdominal structures rubbing up against the peritoneum and aggravating that pain further. You also have pancreatitis as our final important pain history, and that's often epigastric, but it can also refer to the back. It's improved by leaning forward. I wasn't able to find a very clear reason as to why, but I think it might have something to do with the fact that the nerves are pressed less when you're leaning forward and the pancreas sort of comes off them. It's worse after meals. Next up, we have the next question, which is about nausea and vomiting. And in particular, we care about whether there's blood in the vomit as well, which we call hematemesis. So when it comes to the history of nausea and vomiting, again, we care about whether there's blood. So there can be bright red or fresh blood. And that indicates more of an upper GI course, so sort of above your stomach. And that can be in the esophagus with esophageal varices. Again, you're going to be learning about this with portal hypertension in the corresponding lecture. But you can also think about some like common, simple to understand causes like a Mallory-Weiss tear, where something like violent coughing or violent vomiting can result in overstretching and tears of the esophagus, causing blood to leak into it. And then you vomit that up, and that's what you see as hematemesis. You also have coffee ground vomit. So that's sort of a darker colored vomit, and that comes from peptic ulcer bleeds. The reason it's darker in color is because that blood is being digested by the stomach acids, and then you're bringing that up with as you vomit. And that's why it's a darker color, often called coffee ground color. You also have projectile vomiting, and that's where just spewing large amounts, and they often travel large distances. You see that more commonly with babies, and the conditions that can cause it are pyloric stenosis. So that's where the opening between your stomach and your small intestines are sort of constricted and stenosed. And as a result, rather than the food moving down your small intestines, it just gets sort of spewed back up. So babies can classically vomit back up the breast milk or whatever they've been eating. You also have increased intracranial pressure, doing a similar thing. That can also cause early morning vomiting. And both of the reasons behind that is potentially because you have compression of your vestibulocochlear nerve, which again makes you feel nauseous because your balance sense is kind of skewed. And you're going to be learning more about that nerve and everything that sort of it does in head and neck anatomy in semester 2. So don't worry about that too much. A final one I want to cover though is infective causes. So things like norovirus. And whenever you hear the word cruise ship and projectile vomiting, always think norovirus. It's sort of a buzzword thing that you'll come to learn. And then you also have early morning vomiting, and that can be caused by pregnancy, alcohol, and increased intracranial pressure. Okay, we now come to swallowing issue. You also have, swallowing issues. So that's dysphagia. Now with dysphagia, we break that up into just being sort of pure swallowing problems where you have difficulty swallowing versus more specifically, you can have pain upon swallowing, and we call that odynophagia. In terms of causes, there's sort of 3 distinct categories. One is intrinsic being the cause is within the esophagus itself. So that can be things like GORD, where the reflux is causing that, and an obstruction, so a foreign body that someone might have swallowed. Extrinsic is where something outside the esophagus causing dysphagia. So it could be an impinging mass. So it could be a tumor that's outside that's compressing it, an inflamed structure. So think about nearby structures and you can think about what could be that inflamed structure. If you want some help thinking about that, you can go have a look at the anatomy lectures where we covered things like the esophageal constrictions, and that'll give you an idea of what can be inflamed and what can sort of cover up that esophagus. Things like the thyroid, for example, can do that. And then you also have other, which is a very broad category, but you can group them as being neuromuscular as one of them. And that can be things like myasthenia gravis and whatnot. So we'll move on to the next slide now. And here we're going to talk about a couple more GIT history related questions. So first up, we have fullness, which is a very broad category, but essentially it's whether the person feels more fuller than usual, either during the meal, which is called early satiation. So while they're eating the meal, they tend to finish earlier because they feel fuller earlier. And that fullness might be because they feel pain, and so they're sort of eating less. And you can think about peptic ulcers, for example, as being a reason for that. Or it could be an obstruction that's physically stopping how much they can eat during the meal. Something like a gastric cancer that might be blocking the pyloric space. You can also have excess fullness after meals called postprandial fullness. And there's also the next topic, which is appetite. So you can ask about someone's appetite, whether it's reduced, increased. When it's reduced, we call that anorexia, and that can be due to cancer, hypothyroidism, various causes. It can be increased in hyperthyroidism, and that's broadly speaking appetite. And you also have bloating and distension. Bloating is something a patient feels, so it's where the patient feels fuller, or it feels like the abdomen is fuller. Distension is where you can visibly see that the abdomen is larger. And so they both can point towards a bowel obstruction or ascites in portal hypertension. Again, you're going to be learning about portal hypertension in a separate lecture, so don't worry about that too much now. Then you also have your final question, which is bowel habits and stools. So that's where you ask a person, are they passing wind, which is also called flatus. And importantly, again, we care about blood here. So if there's blood in the stools, they can be broken up into two categories: hematochezia being sort of fresh pink red blood, melena being darker red blood, which is digested. All right, so when it comes to stools, I've got some potential causes for each of these. So hematochezia, bright red fresh blood, can be due to a lower GI bleed. So things like hemorrhoids and colorectal cancer, where the bleed is sort of in the lower GI tract and hasn't been digested, and so it's still quite bright red. Melena is more of your tarry black, darker blood, and it's sort of tarry black because it's been digested. So that could be an upper GI bleed. So it's an esophageal bleed, something in your stomach like a peptic ulcer being digested and being brought down into your stools. And then you have steatorrhea, which is fatty, foul-smelling floating stool, usually caused, broadly speaking, by fat not being absorbed properly, and that can be caused by things like pancreatitis. We are not producing the proper enzymes to break down the fat. Celiac and Crohn's, which is malabsorptive disorders, and gallbladder and liver issues. Another one which you can throw in there is cystic fibrosis, and again, they're all gonna cause that steatorrhea. You also have early morning, that shouldn't be there, but those are the three categories of stools that you can broadly think about when it comes to the history. All right, and then you also have your final two questions, which are color changes, which is basically talking about jaundice, and your systemic features. So color changes refers to, with jaundice, yellowing of the skin and the sclera, but also changes in your urine and feces. And I've got examples of what those changes could be on the right-hand side there. So with prehepatic, intrahepatic, and posthepatic, you can expect certain changes in the urine and stools. And you're going to be learning about how that occurs physiologically, the underlying principles for that in a separate lecture as well. Systemic features are things like fever, night sweats, fatigue, weight changes, trouble. They're all sort of pointing towards like infection or malignancy, but weight changes in particular could be due to other sort of GIT related pathologies. Like if you're not absorbing fat, for example, that we saw in that previous slide, you might not be able to gain a lot of weight. So that's why CF patients might have weight loss. All right, so that was it for the GIT history. Let me know if you have any questions or any concerns about what we covered today. Otherwise, for your OSCEs, the main content is on this slide. So all the questions sort of clustered into one slide. So you've got pain, nausea and vomiting, GORD. So do you feel any acid at the back of your throat, swallowing difficulties, fullness related sort of during or after meals, appetite changes, bowels and stool changes, bloating and distension, color changes with jaundice, and systemic features. Again, there's probably a lot of mnemonics you can find online to remember it. Because it's a sort of a longer history with a lot more things in it, it's kind of harder to cluster it into a useful mnemonic. I've got one down there on the screen, but you can think of it in terms of just locations. So you might think about, for example, when you're looking at someone's upper body, and their face, you might think about things like jaundice, you might think about things like appetite in terms of the oral intake. And then when you move down to the stomach region, you might start thinking about distension and bloating. So you can break it up into sort of locations and asking questions related to locations, whatever works best for you in terms of memorizing those questions. But that's it for the GIT history.